You have disabled participant screen sharing.
Have I? How did I possibly do that? There you go. Multiple should work now.
Right.
And I started recording, everyone. There we go.
Right. So can everyone see that okay?
Yep.
Okay. All right, let's start. So it's lovely to spend some time with you. And I'm aware that some of you know about clinical reasoning, and you're probably very highly skilled in clinical reasoning. And even those of you that aren't familiar with the model, if you're a good nurse and a good educator, which I presume, and from feedback you are, then you engage in clinical reasoning in an intuitive way, probably without even knowing it. So this, in many ways, will be an introduction and a reinforcement of what you know and what you already do. But it's really important to come back and say, all right, I may be very good at clinical reasoning. That doesn't necessarily make me very good at teaching clinical reasoning, because it's a complex skill to teach. What I do want you to do is to interrupt me and ask questions at any time. Okay, please don't hesitate if I'm going too fast or it's not clear or you disagree. Please step in. I love being challenged, so go for it. So what I thought I'd focus on is clinical reasoning, why it matters, what it is, the model that we developed about 12, 13 years ago, the errors and biases that can prevent or impede effective clinical reasoning, and why and how clinical reasoning links to empathy. You actually can't be good at clinical reasoning unless you're highly empathic, unless you've got very well-developed therapeutic communication skills, and you're also good at person-centered care. So, why did we focus so much on clinical reasoning? It's because of patient safety. Healthcare errors are the third leading cause of death in the developed countries. So after cancer and heart disease comes clinical reasoning, comes healthcare errors, sorry. So the important thing is that 50% of errors, and some people say up to 80% of errors, are preventable. 5 people die every minute in Australia because of unsafe healthcare. 17% of hospital admissions result in a serious adverse event. And as I said, 50 to 80% are preventable. You know, they are just statistics though, and they fail to depict the distress and the disability caused to patients and their families when things go wrong in healthcare. And, you know, the Australian healthcare system is relatively safe compared to other countries, but even in Australia, it's safer to work in a nuclear power plant or to go hang gliding than to be a hospital patient. And the irony is that if you look at it, for example, as look at a hospital or a healthcare local health district, the number of people who are highly educated, extremely committed, and highly skilled, and yet things still go wrong. So, you know, we've got a real problem, and we need to understand the things that go wrong, why they go wrong, how they can be prevented, and what our role is as educators in helping students and graduates prevent adverse patient outcomes. Because universities do have a distinct and important role to play in improving patient safety, we're not just here to give students a whole lot of knowledge and skills. Their knowledge and skills have a direct and long-lasting impact on patient safety. And there's a whole body of research that talks to that. So how does clinical reasoning and patient safety, what are the connections between them? You know, when we think of things going wrong, we often think, well, that person didn't have enough knowledge or they didn't have enough skills. And actually, knowledge and skills are rarely the cause of errors in healthcare. Clinical reasoning is a factor in nearly 60% of clinical errors. And nurses without well-developed clinical reasoning skills often fail to identify, predict, or prevent errors, or to recognise and effectively manage at-risk patients. The other thing to keep in mind is that adverse patient outcomes are related to communication. So between 70 and 90% of errors that happen in patient safety are related to communication, and clinical reasoning and communication go hand in hand. So there's a whole body of research that shows that healthcare reports often describe critical patient incidents which involve poor clinical reasoning by graduate nurses, also graduate doctors. And the most risky time to be a patient in an Australian public and private hospital is February, March each year, because there's a higher number of graduates. And that's really scary, and that really speaks to our responsibility to do something about it. There's been an ongoing huge study in the US where there have been at least 10,000. The last time I looked, about 3 years ago, there were over 10,000 graduate nurses that had been in that study. And they identified that students who had graduated, they had passed their NCLEX exam, so the national exam, they had their license, and they had worked for a minimum of 6 months. When they were assessed for their clinical reasoning skills, 70% of them scored at an unsafe level. So despite getting through an undergraduate degree, they still didn't have the clinical reasoning skills needed. It's interesting because in that study, they also looked at registered nurses and their clinical reasoning skills, and they found that 25% of them also scored at an unsafe level. And they were registered nurses who had been practicing for at least 10 years. And we probably know a lot of registered nurses that are kind and sometimes organised, but they're just not super effective. They're not the sort of nurses that we would want caring for us or for our family members. So, and they're the ones that worry me. Patricia Benner, the nursing theorist, refers to those as the experienced non-experts. So they've been doing the same thing in the same way for many years, but they were never profoundly safe. We conducted a study a couple of years ago, end of 2018, where over 2,000 final year nursing students from Australia and New Zealand participated. And that study also identified a number of concerns, including deficits in clinical reasoning. So these were the results of that patient safety study. And you can see that communication and therapeutic communication and person-centered care, the students scored overall at a really high level, and the average was 81% for person-centered care, 76% for therapeutic communication. For clinical reasoning, the average or the mean was 74%. However, I'm going to show you how that result was really quite skewed. Teamwork and collaborative practice, the average result was 73. Cultural competence, 75. Preventing, minimising and responding to adverse events, the score was 60%, but that result was also highly skewed. Evidence-based practice, 55%. Medication safety, 50%. So it's a real problem, and that's why it's part of the subject you're teaching in now. And infection prevention and control, 49%, which is particularly problematic when you think of the pandemic we're currently experiencing. So if we look at the graph here, all of the yellow graphs represent universities where clinical reasoning is explicitly taught. So it's part of the curriculum. They use the clinical reasoning model. They use the clinical reasoning textbook in at least 3 subjects. So in those universities, their students' clinical reasoning scores was much higher. All of the blue ones were the lower ones where clinical reasoning was referred to, but they don't actually teach it in an explicit way. And those, as I said, those universities represented by the yellow graphs also use the clinical reasoning textbook. Okay, here's a little test for you. One of the things we do as educators is point out the subtle nuances of clinical scenarios. And the idea is that when we do that, students will learn, if they learn it in a really effective way, more importantly, if we teach it in a really effective way, then the clinical scenario and the details of that clinical reasoning scenario will be unforgettable. So this is an example of that. I want you to tell me, so you need to take your mute off, and tell me what that is a picture of. Now, this is a test used by psychologists, and they say that in any given group, a minimum of 25% of people will see that picture and know what it is immediately. So where's my 25%?
Oh, no pressure, Tracy. Is it a leaf?
Does look like a leaf, but no, it's not.
Oh, my bad.
Who else can see what it is?
I can't say anything.
Can't see
I can see all sorts of things.
Yeah, I can see
It's kind of
a pig snout on the right-hand side. I can see the map of England on the other side.
I can see a penguin.
You're seeing things that I can't see. Okay. All right. So as educators, what we do is point out the features and the nuances of clinical scenarios so that students don't forget it. So it's a little bit like doing this. Can you now see what that is?
Yeah, or a calf.
Oh, it's a cow.
That's the snout I was seeing.
Yes, yeah, very close. And the idea is that we point it out. So in our teaching, we say, look, here's the, the ears, here's the nose, whatever. So that, what we want is that it will become a mental model. So that, 12 months or in the next placement or even when they graduate, they will look at a clinical scenario and say, I know that, I've seen that. And if I show you that, can you still see the cow?
Oh, yeah, no, you can.
Yeah, absolutely.
You sure you didn't change it a little bit? I want to see the original.
So the idea is if our teaching is effective enough, and that's the test, we sometimes say students didn't learn this, but we also need to say, did we teach it? Did we teach it in a way that was effective enough that students could, that it was meaning and memorable for students?
Yeah.
So clinical reasoning, what do you think it is? And what I want you to do is reflect on, if you went in and you saw a 16-year-old boy who had significant pain and his mum was there and she was saying to you, he's had this pain now for 2 days. His elective surgery, minor surgery, for example, appendix, but he's, wasn't discharged because of the pain. What would be your thought processes?
I'm just
What would you be thinking as, if you walked in and you saw that situation? A young boy in pain.
Could be various reasons. Maybe I would think maybe something's they didn't do right in the surgery. There could be something sitting there, maybe a gauze piece.
Yep.
Or I could be thinking maybe it's an infection because of that or some other reason. And he's, of course, it needs to be identified quickly what is causing the pain. We may be able to give pain relief, but that's not the answer. But we need to find out what is causing the pain.
Yep.
So you establish a short-term and long-term goal for it. And especially immediately, you need to make sure to find out the cause for that particular scenario. Because it's not normal for a child for post-appendicectomy to have such pain.
Absolutely. Absolutely. That's really good. Would anyone add to that? What else would they be thinking? What would you be thinking?
STD. And he doesn't want to talk about it in front of his mum.
Right.
No, I mean, I don't.
No, it could be. It could be 16.
Yeah. But just what Molly said, I think, just can't assume. You've got to find out the etiology.
Yes. And I think that's the key thing. But sometimes what we do is jump to a diagnosis, jump to actions without saying, where do I start? And that's particularly important for students because they don't have the knowledge and skills to jump to a diagnosis. And we actually don't want them to, because that's premature closure. You know, going straight to a diagnosis before you have all the information, you know, that's a recipe for disaster. What we realised in 2008, I was working at the University of Newcastle, and at that time we had a 6-hour face-to-face clinical assessment that was done in a clinical setting with students in their final semester. And the educators went through a 2-day training on how to assess those students. And what we were basically saying, are they safe? Would they, you know, would we be able to sign them off as having the knowledge and skills they need to practice safely? So it was a very comprehensive assessment. And after we did after the first year, what I noticed in their documentation and in their reports back to me was things like they would say, you know, Tracy, that student has a lot of knowledge. You know, and they've got some really good clinical skills, but what they don't have is critical thinking ability, problem solving ability, insight, clinical judgment skills. And when they started talking to me about it, they were all using different terms. They were all using different definitions, but whenever they could identify there was a lack of critical thinking or lack of insight, it led to an issue. And I said, this is incredibly important. If this deficit that you're identifying is leading to problems, we really need to understand it more. And we need to be able to teach students the skills they need to prevent and to identify problems in practice. So that's where the whole notion of clinical reasoning started. After looking at lots and lots of studies and research, we decided that clinical reasoning was the most appropriate term because things like clinical decision making, that's what happens after you've started to engage in clinical reasoning. It's not what we do first. Insight is very hard to define. Critical thinking skills, you know, your mechanic should have good critical thinking skills. So that's not unique to nurses. So we wanted something that was unique to nurses and in some ways, healthcare professionals. Now, I have to confess to you, when we developed the model I'm about to show you and that you've probably seen, I thought to myself, you know, I'd been a clinician for many, many more years than I'd been an academic, and it resonated with me. And I thought, you know, this is how I think. And so I asked a lot of clinicians and a lot of practicing clinicians and educators, does this work for you? Is this how you think? And they kept looking at it thinking, you know what, you've laid out how we do think. Sometimes we're not even aware of our thinking, but that is it. Then this model is now used in Stanford for teaching anaesthetists and in Boston for teaching all sorts of doctors. And so I said to them, is this really how doctors think? And they said, this is it, and this is how we teach it. And for too long, we've gone to the hypothetico-deductive model, and it really doesn't teach. It allows for guesswork, which is not what we want. So this model's being used in a lot of medical programs, also in Australia. And the other, serendipitously, one of my colleagues was doing her PhD at the time, and she was spending time in clinical practice observing registered nurses and asking them to think aloud, which is very hard to do. But she taught them to think aloud when they were caring for very sick patients that were having AAAs. And then she interviewed them afterwards. And what she found was there were two clearly defined groups. Those that collected lots and lots and lots of cues, but really found it difficult to make sense of it. Those that collected less cues, but they were focused. They knew what they were looking for and they were able to make sense of it. And when we analysed their thinking processes, they aligned perfectly with the clinical reasoning cycle. So we became a lot more confident and said, you know, this represents what good registered nurses do. And so we need to teach it. And this is the definition that we came up with. The process by which nurses and other clinicians collect cues, process the information, come to an understanding of a patient problem or situation, plan and implement interventions, evaluate outcomes, reflect on and learn from the process. What we realise though is that nurses' clinical reasoning is different to other healthcare professionals. Why do you think it's different to the way a doctor might think, or a dietitian might think, or a physio might think? Because it's similar but not identical.
Because we are always with the patient, first of all. We understand even the, we are sort of attention to detail in a way that even as minute complaint a patient has, then we are the one knowing. But when you tell the doctor, they might look in a big picture. But as nurses, we are the one very close to the patient. And so any little change that happens to the patient, we are able to identify. Even a minute ago, patient was like this, but right now there's a change in patient's condition. So we are able to understand quickly in order to, I think, than doctors. And what else? Of course, our theoretical knowledge as well, in addition, as a nurse, as an expertise in our clinical practice.
You know what? If I could give you a gold star, I would, because you've just nailed it. That is so true. A lot of other healthcare professionals, a lot of other, allied health and even medicine, they treat and retreat. So a physio will come in, and physios do very comprehensive assessments. And I say that, my daughter's a physiotherapist, so, she does comprehensive assessments, but they treat and then they retreat. So, but nurses are there for hour after hour, and they pick up subtle changes, as you've said, and that's critically important. The other thing that nurses engage in is person-centered care. So they're looking for the physical changes, but they're mindful of the emotional and the psychosocial. They're looking for interactions between family members. Somebody said they could have that young boy I mentioned could have, sexually transmitted disease. So nurses are always thinking in the moment, but also outside the square, and they're very good at connecting the dots. Other allied health professionals certainly engage in clinical reasoning. And I've written a book with other allied health professionals. They're good at it, but it's still different to ours. And we bring what I think is a much higher sense of importance, because we know, we see those subtle changes, and we see the whole patient, and we are holistic in our approach, which means that we have a huge responsibility. So this is the model we came up with. What we wanted was a model that we could teach, because clinical reasoning is complex. And when nurses and other healthcare professionals become experienced, often this model is hardwired. So they're not even aware they're engaging in clinical reasoning. It just becomes a mindset. And much of it is kind of intuitive, which I'll talk about in a moment. A lot of it is stored in long-term memory. And the challenge for students, particularly in simulations and in practice settings, is that they can see what registered nurses do and they can hear what they say, but they can't tell what you're thinking. And it's those detailed, highly sophisticated thinking processes that are critically important. So what we decided was we needed to break it down, and we needed to pull out, how do good nurses think, so that we could actually teach each of the stages. Now this looks like a beautiful symmetrical circle, but I'm mindful that sometimes the stages between the 8 stages, sometimes they blur, sometimes registered nurses go forward and then go back and collect more information. So even though it's presented here perfectly, we know it's not always a perfect approach. But it's a little bit like if I was going to teach a student to catheterize a patient, I would break it down into steps, and I would try to teach the perfect process so that students were aware of it. And it would take me ages because I would deconstruct it and teach them little stages, much like this cycle. But, you know, I worked on a gynecology ward. If you asked me to do catheterization, you know, I could do it in 3 minutes with my eyes closed probably because I'd done so many. But if I was teaching it, I needed to break down the steps and do it slowly and deliberately. And that's why in our undergraduate degree, students in their first semester really just learn the first 3 stages. And it's not until in their second section that you are charged with the responsibility of teaching the whole clinical reasoning cycle and helping them to understand it, understand its significance, and you're also assessing it. So I'm going to go through those stages now, and I'm going to give you a little activity to do with the very first stage. So the very first stage is consider the patient. So when you consider the patient, you're looking at the facts, you're looking at the context, the objects in the room, the people in the room. And it's a little bit like if you see someone, you come to a judgment about them within about 10 seconds. You've made decisions and assumptions and formed judgments about them even before you know you've done it. It's what good nurses do when they go into a room. What do they see and how do they make sense of that situation? So the 2 things that define this stage is anticipating, because if you knew you were going in to see a 16-year-old boy who had his appendix out, you'd anticipate what he should look like, what state he should be in, and when you got there, you'd notice. So this stage is about teaching students to anticipate and to notice. So I'm going to show you a little video. I think it goes for about 30 seconds. And this is about noticing. This is about looking at what you would see if you walked into this patient's room. Perhaps if you walked in and you watched a new graduate nurse, what would you see? And what would concern you? So I'm going to show you this video, and I want you to cross your fingers that it works okay. And I want you to be thinking and even writing down, there's 16 problems in this 30-second scenario, and I want to see how many of them you notice.
Hello there, your nurse said you're in some pain, so I'm just going to give you some Panadol. I'm just going to check your cannula while I'm here. All right, looks good. Okay, I'll just pour you some water. All right, and I'll leave it over here for you.
Follow up on this CT for Mrs. AM. She's quite unwell, so it needs to be a priority.
Okay, all right. Okay, gotta go. All right, sorry.
Okay. Tell me some of the things, if you walked into that room, what would you be worried about?
The first thing is thickened fluid.
Thickened fluid, yes, absolutely. Was she being given thickened fluid?
No, she was given water.
Yep, absolutely. So that's one. What else?
And Panadol as well. I don't think you might have to crush and mix it with the thickened fluid. You can't just leave it there.
Yeah. Can you crush paracetamol?
You can. Or you can get a liquid, which is thick as well and can be mixed with the thickened fluid too.
Yeah, good. What else did you see that would worry you?
It's got a very small screen, but is that cords all over her body and up the, I don't know what that cord is. Is that a phone or something?
So normally this would be shown in a lecture. Yeah. So what you can see on the patient's chest is her Hudson mask.
Oh, right. No, it'd be better on her face.
And what you can also see hanging on the IV stand is the her bell, handbell. Yeah. Patient.
Oh, right. Okay.
Which really doesn't help.
Can I interrupt? Judy says it says here that the screen is frozen.
Yeah, my screen, I couldn't, it's just
Yeah,
frozen.
mine's frozen as well. Yeah. Mine's
But even with the frozen screen, the two things that I see is this, just a syringe sitting on top of the chest and very little urine output. But as I said, I didn't see any footage. I could only hear the dialogue. But
I'm sorry. Okay.
it's okay. No, it's probably we're switching over to NBN at the moment. So I think we've kept our old internet, but I think there's some, I don't know.
Could
all those cords everywhere.
Yeah. Could any of you see the video?
no. Oh, not me.
No, not the video,
Okay.
but I can see the picture.
All right. Yeah. All right. So what else, can you see anything else in that picture?
I don't like where the urine bag is.
Yeah, that's too high.
That's
And
another.
also water, patient cannot access the water.
That's right. That's right. But we don't want them to access the water because
No,
she's
so probably just.
And then the syringe on the next to the patient. I don't know what that is. It could be normal saline, it could be something else.
absolutely.
I feel that she just walked into the room and gave Panadol, but she could do her identity check because we don't know which patient she's talking about. She hasn't done an identification about whether she's going to do with the right patient. She did not get a consent from the patient. She just walked in and she just started saying that I'm going to give you this, and she did then, she just walks off and not even waiting to ensure that patient is sort of taken the medication and patient is comfortable and things like that.
Absolutely.
I've only heard the dialogue. There seemed to be some sort of an interruption near the end, and she just, I'm assuming, just walked off.
Yep.
Didn't finalise her encounter, and the patient's got, which we know is now contraindicated for patients unless they're confused. I don't know if that's,
What's contraindicated, Judy?
Well, the recommendation is bed rails should always be tied for patients.
Absolutely.
Yeah, so they don't climb up and out.
Yeah. What is the first thing that nurse should have done when she walked in the room?
Introduce herself.
Yeah. Or at the same time or even before?
Before what, sorry?
The first thing she should have done before she interacted with the patient?
I mean, checked her notes and stuff.
Getting a consent.
Wash hands.
Well,
Yeah.
And hygiene. There was none of that.
of course, infection coming. Oh, yeah. And also, we don't know whether this nurse has done a pain assessment before and bringing the Panadol doesn't say that.
Yeah.
Because we don't know where the pain is. Is it a headache? Is it a stomach ache? Or we don't know why she's giving Panadol. Yeah.
And
It's
also,
hard to, it's hard to see in this picture, but there's a key in the top.
Yeah, I saw that.
Yeah, is that I mean, if that's a medication drawer, then that's a big no-no. But even if it's patient's belongings.
Yep, absolutely.
Yeah.
And can you see the box that the gloves should be in?
Oh, yeah, it's empty.
Oh, there's no gloves at all.
Hard to see, but that patient's obs are also problematic. So I'm going to just show you the list now. Okay, so there were many issues. You couldn't see this because it was meant to be on a big screen, but the oxygen saturation levels were 88%, heart rate 105, the oxygen mask was on the bed, call bell out of the patient's reach, bed rails up and the bed was too high, syringe on the bedside locker. So you really did quite well. Syringe on the bedside locker, empty glove box on the wall, catheter bag too high on the bed, no hand hygiene. She was interrupted. Medications were left on the bedside table, and even if she should have taken the paracetamol, you wouldn't leave them there. There was no ID or allergy ban check. She was given water despite the thickened fluids only sign. She checked the IV cannula, which now I know you couldn't see, but she never checked the IV fluids. There was no documentation completed, and the keys were left in the bedside drawer. So when you are teaching students, wherever, in classroom, in labs, in clinical settings, it's really important, and this is the first stage of the clinical reasoning cycle, get them to anticipate and to notice. And I used to be a new graduate coordinator, and the number of times I'd say, right, let's go in and see the patient. And the new grad would go and check, you know, the infusion pump, and they'd go and check the PCA, and they'd check the charts, and they would forget to actually look at the patient. You know, just looking at a patient gives you a wealth of information. So what we need to do is help students look at the person and gather information just by looking at them, their position, their facial expression, their body language, you know, even the bed. You know, if the sheets are all in a mess, you know, what does that tell you? That patient might have been tossing and turning. So we need to, in the very first stage of the clinical reasoning cycle, there's a wealth of teaching opportunities. Okay, the second stage. And we've broken this into three because even though the clinical reasoning cycle in some ways is a little bit like the nursing process, what we realised was the nursing process didn't provide enough detail, enough description, or enough information to take students on the learning journey. So we had to break it down into stages, and each stage is based on what we actually know nurses do. So they review. Nurses review the current information that they have, so handover, what they heard in handover, what they know about the patient history, the patient charts. They're aware of the results of any investigations or any previous nursing and medical assessments previously undertaken. So they have that as their background information, and they should, you know that nurses should always look at all that information before they go to the next step. And then they gather new information. So undertaking a patient assessment. And when I say to students, okay, what does that mean? They will say to me, oh, A to G or TPR blood pressure, or, you know, they give me very limited information. So those things are critically important, but we also need to teach students the meaning of a focused assessment. So a thorough pain assessment, a thorough fluid status assessment, because one of the complaints that clinicians make about graduates is that they don't have highly developed patient assessment skills. So we need to focus much more on that. When I was in the US a few years ago, what I noticed was they really teach patient assessment back to front and inside out. I don't think we do it well enough. Then what we need to do, now this is easy for registered nurses because you have a breadth and depth of information and knowledge that you can readily call on. And that knowledge includes physiology, pathophysiology, pharmacology, epidemiology, therapeutics, best practice, culture, context of care, ethics, law. You have all that. But for students, it's a little bit like they have a lot of knowledge. They learn a ton of information. But it's like their knowledge is just thrown on a pile on the floor and they have to wade through it to find out what is relevant to this particular person. But for experienced nurses, it's like they have a filing cabinet in their mind and they can just pull the right information without even knowing they're doing it because they have so much experience to call on. So we need to make sure our students have real knowledge. And when students say to me things like, oh, you know what, is attendance that important? Do I really have to go to lectures and tutorials? I say to them, if you don't have the knowledge you need, you will never be safe. It's no good being in a critical situation and say, I'm just going to go and look up a journal article. You need this knowledge. You need depth and breadth. So that's the second stage. This is my favourite stage because I think this is the beauty of nursing. This is the art and the science of nursing, and it's where nurses stand apart. So in the process information stage, there's a number of components. So the first one is interpreting. So you analyse the data to come to an understanding of signs and symptoms. You break it down into individual parts and you say, is the temperature normal? If it is, maybe I can move that to the side. Is the pulse rate normal? No, it's thin and thready or weak, you know, tachycardic. Right, keep that here because I need to think about that. So it's looking at each one and saying normal, abnormal, should I be worried? And then it's also discriminating because we cannot focus on everything at the same time. So we need to say what is critically important here, and there are all the abnormal signs and symptoms. We look at inconsistencies. We narrow down the information to what's important. We recognise the gaps and we say, whoa, I forgot to check the urine output. I forgot to check the specific gravity. I know the patient's pulse is weak and thready, but you know, what's their input been? And I have to check their mucous membranes. So it's saying, what do I have? What do I still need to get? And this is the beautiful part, discovering the relationships or the patterns between that information, synthesizing it, clustering the cues together. It's a little bit like a jigsaw puzzle, and good nurses do this, and they do it beautifully. They bring all the different parts together and they see the pattern. And this is something we need to help students do, because what they tend to do is look at the individual parts as individual parts, and we need to show where the relationships are. So if we, you know, had a student that had, a patient had low urine output, hypotensive, weak thready pulse, tachycardic, dry mucous membranes, we would start to think that patient could be hypovolemic or dehydrated. We start to draw a picture in our minds. And then we infer, we make deductions or form opinions that follow logically by interpreting the subjective and the objective cues. And we say to ourselves, yeah, it could be dehydration or hypovolemia, but it could also be this, and it could also be this. It's most likely to be this. So we have that conversation in our mind, and often we don't even know we're having that conversation, because this is in part of our long-term memory. And it's because of the next stage, matching. So we match the current situation to past situations, or the current patient to previous patients. And that's an expert thought process. We have a whole repertoire of similar situations that we can readily call on. And so we sometimes call this intuition. It's really not intuition. It's that just pattern matching. We've got such knowledge and skills that we can readily say, I've seen this before. You know, I know what's going on here. And the other expert thought process is predict. And it's, you would say, I've seen this before. I'm really worried. If I don't get that patient some IV fluids now, then they're going to go into hypotensive shock, because I've seen it happen before. So it prompts us. The only challenge is that nurses are also incredibly optimistic. And there's some really good research that says that we tend to think, you know what, I think they'll be okay. You know, their blood pressure's not that bad. Their pulse rate's not too bad. I won't contact the doctor yet because, you know, I think they're 16. You know, I think they're going to be okay. We need to become much more pessimistic and say, if I don't do something now, what's the worst thing that could happen? And allow that to guide our thinking and our actions. Right, we've got all that, and then we synthesize and we bring it all together and we make a definitive nursing diagnosis of a patient's problem. And this was the most controversial stage when we were designing the clinical reasoning cycle, because so many people said to me, nurses don't make diagnoses, that's the doctor's job. And my argument is, hang on a minute, nurses are highly educated and very experienced. If they can't say that patient's blood glucose level is 2, that is hypoglycemia, we've got a problem. They may not be able to diagnose, and we wouldn't want them to necessarily diagnose cancer, but we want them to be able to come to a diagnosis about dehydration, hypoglycemia, things that are in a nurse's remit. We need them to make a diagnosis, because unless you come to a diagnosis, you don't know what to do next. It can't be guesswork. It has to be a very clear nursing diagnosis. But when we're teaching it, what I like students to learn is we don't use the NANDA nursing diagnosis or the NIC and NOC that they use in the US, but I do want our nursing diagnosis to be very informed. So, for example, dehydration related to vomiting, pre-operative or post-operative nausea and vomiting, evidenced by dry mucous membranes, oliguria, weak and thready pulse, because that allows students not to guess. They say, this is the diagnosis, this is what's caused it, I think, and here's the evidence of it. It really solidifies their thinking and stops the guesswork. Then we need goals, because if we don't have goals, we don't know what we're focusing on. But it has to be very specific, and it has to have a desired time frame and a desired outcome. I want this patient's urine output to be at least 30 mils an hour within the next 2 hours, because then we know whether we've achieved our goal. Has to be measurable. And then we take actions. And sometimes for an inexperienced nurse, a student or a graduate, their most appropriate action is to refer the matter to someone else or get advice. I think, and always with students, they should never just say, there's a problem. They should say, I think that the patient could be dehydrated because of this, because they have to be intelligent enough. They can't just say, there's something wrong. It has to be informed. And then for nurses, you know, they have to identify the appropriate action, you know, get an order, get a clinical review, rapid response, increased IV rate. There's multiple alternatives, but they have to select the most appropriate alternative for this patient at this time. And then they evaluate and they ask, has the situation improved now? Is the urine output 30 mils an hour? If not, was my nursing diagnosis wrong? Were my actions wrong? Do I need more time? What do I have to do, excuse me, now? So you have to evaluate. And then reflect. Contemplate what you've learned from this process and what you could have done differently. So if increasing the IV rate did not improve the patient's situation, then you have to think about that and think, you know, something's gone wrong here. You know, I haven't got it right. I need more information. And, you know, reflection has become a real negative in nursing, and particularly for nursing students, because they think, oh, another reflection. But we need to teach them that reflection is integral to learning. And it may not be always a formal, written, structured reflection, but no nurse that I know has ever driven home from a shift and not reflected on what happened on that shift, what went well, what didn't go well, what they wish they'd done or hadn't done. It's part of who we do, or who we are and what we do. And I haven't worked clinical shifts now for probably 3 or 4 years, but I would always work Saturday morning. And 9 times out of 10, I would ring on my way home and they'd say, it's Tracy, she's forgotten something. But it was always because I was reflecting, and I'd think, tell the nurses to check that. Tell the nurses to check that. I can't remember if I've done that, because we just do that. That's what good nurses do. Now, you know, I told you that that model is beautiful and well structured and is based on research, and we know it works. But, you know, the whole thing is flawed unless we really are aware that deep inside us, we all have clinical reasoning biases. And that can, you know, make an error of everything, even if we're well intended. Because our preconceptions, our assumptions, our biases, our stereotypes and stigmatism can negatively influence clinical reasoning, and sometimes even prevent clinical reasoning from occurring. So if we say, for example, women from that culture always whinge, you know, when they're in labour, you know, it's just them, then we're not going to stop and say, hang on a minute, is their pain normal or abnormal? You know, is there vocalization of their pain? Is that something I should worry about or not worry about? Because when we cluster people together and say, oh, those people, we know we've got a problem. So what we have to do with students is help them to become aware of their biases that we all always have. You know, I used to always have international students that would stay with me, you know, for 3-6 months. And, you know, what I realised was it was fantastic for deconstructing errors and biases, but sometimes it created biases. I remember I had a gorgeous young girl from Peru. She never cleaned her bedroom or bathroom, ever. And I was always nagging her. And in the back of my mind, I was going, you know, Peruvians, do they not have any sense of hygiene? And I thought, for goodness sake, Tracy, it's one girl. You know, and I'd only have to go into my teenagers' rooms, and their rooms are disgusting. And I was saying it was because of them, it wasn't because of their culture. So it's really important that we always think about our own biases and really help to become aware of them, because they influence everything we do in our clinical practice, in our day-to-day lives. Problem is that many of our assumptions and prejudices are long-standing and deeply embedded, and we deny we even have them, even if we're aware of them. So I don't know whether to show you this video now. I'll show it. It's only, 10 seconds. Hopefully you can see it, but if you can't listen to it, it is a nurse that goes in to see one of her patients. If you can't see it, I'm going to tell you about it in a second. I hope you can at least hear it.
Are you all right, Mr. Brown? Just what we need today, another one with dementia. Oh.
So could you see it?
No, I heard it but didn't see it. But I tell you what, just listening to it, I think it was quite confronting. It was kind of good. It was such a horrible statement to make, and hearing it, yeah, it was.
So the man was actually doing, that picking, they pick it, people sometimes pick at the bedclothes, and he was going like this because his head hurt and he was not responding verbally clearly. So the nurse looking after the other patient looked over and said, just what we need, another one with dementia. There was no evidence of dementia. Confusion, yes. So why might...
Sorry, Tracy, can I just say exactly what you described is what my dad was doing when he was taken to hospital with a temp of 40.1 and he was septic.
Right.
And the first thing they asked me in ED is, does he have dementia? And I said, no. And they said, is this normal behaviour? I said, absolutely not.
And that is perfect, because we should, if we ever see a confused person, could be dementia. It's quite likely it's many other things. What else could cause a man, for example, in their 70s to be confused? As Judy said, sepsis. Yep. What else?
Derangement of electrolytes.
Absolutely.
Yep.
What else?
UTI.
Opioid toxicity.
UTI. Yep. What was
Medication reaction.
Medication reaction.
New environment.
Yes, absolutely. A new environment.
Post-op, I see often people came out very confused, disorientated.
Yep. Yep. And, it could be the anaesthetic gases or the medications used. It could be fluid and electrolyte imbalance. What's a common one that too often older people are brought to hospital, to ED?
A urinary tract infection.
Yeah.
Yeah, and what's the other one?
Dehydration.
Dehydration.
Or
One other common one.
Like polypharmacy, they've taken them.
Oh yeah, polypharmacy.
falls, actually, there are a lot of fall cases, falls.
Yeah, falls. What about something beginning with C?
Or
Cognitive issues.
Constipation, absolutely.
Oh,
So
okay.
there's so many things. And if we just jump to conclusions, if we allow students to jump to conclusions, then the thinking stops. Premature closure, you don't have to think because you know what's wrong. It could be wrong. But what happens is and they found it with, particularly in medicine and doctors, if you jump to a conclusion, nurses or doctors or anyone else, thinking stops. You don't have to keep thinking because you know what the answer is. So that nurse's clinical reasoning is an example of ascertainment bias. In the clinical reasoning textbook, what we did was look at all, there's hundreds of cognitive biases or cognitive errors, and we took out the ones that are most common in nursing. And ascertainment bias is when a nurse's thinking is shaped by prior assumptions and preconceptions. For example, ageism, stigmatism, and stereotyping. So we've got a whole lot of errors that we're prone to. And the more we understand them, unpack them, the less they influence our thinking. Because clinical reasoning can impede a nurse's ability to recognise and respond appropriately to patients' needs. I asked you what might have caused Mr. Brown's confusion, and you got all of them, and you added some extra ones. So, which gives me great confidence that you're the right people to be teaching our students. Now, I'm going to show you a video, but I think what I might get you to do, Judy, is show this video, because it seems that there might be a problem with my screen sharing. So this video, I think it goes for about 3 minutes. It's a true story. It's narrated by Lewis's mum. And I'm just going to show you the 3-minute version. There's also a 10-minute version and a 1-hour version. And every single time it catches me unawares, because this was an adverse patient outcome that should never have happened, that was informed by both clinical reasoning errors and also poor clinical reasoning skills. Lewis was a 15-year-old boy who died following elective surgery as a result of absolutely preventable post-operative complications. So Judy, if I stop sharing, can you go to the PowerPoint and show this video for me?
Sure.
Then we'll come back to my screen afterwards.
Okay. Let me know if same thing's happening.
Okay. And if it does, we'll just skip it.
I'll put up the link anyway.
Yeah, that'd be good.
Can you all see this?
I can't see it yet.
He went into the hospital. He was slightly dehydrated. He was not producing urine. And
Judy, you're not screen sharing, I don't think.
Sorry?
I don't think you're sharing your screen.
I thought I was sharing my screen. Hold on. Oh, hold on. I am sharing my screen. You can't see it?
No.
Let me just sort of. Oh, no, I'm not sharing my screen. Am I? Right. Am I sharing my screen now?
Yes. So now go into the link.
Yeah, where's it gone? I just had the link. Current slide, click. Okay. Are we all seeing it now?
Yep.
Okay.
when he went into the hospital, he was slightly dehydrated. He was not producing urine. And after his surgery, he was prescribed a very low IV drip, something more appropriate for a small child than a 15-year-old boy, certainly for a 15-year-old boy who was already low on fluid. And we could not get those orders changed. Finally, a pharmacist rounded, and there happened to be a very receptive nurse who was a knowledgeable nurse. Most of them were very young, and they were not going to challenge anyone. But this was an older nurse who really knew what she was doing, and she and the pharmacist got the orders changed. For his pain, he had an epidural with hydromorphone and bupivacaine, and he had, for an adjunct medication, IV Tutor every 6 hours. The narcotics were up to, very high levels, sort of dangerous levels for somebody who was opiate naive. And then the ketorolac, which they kept giving, and it seemed to really have no effect on the pain. At 6:30 Sunday morning, which was half an hour after a Toradol injection, he was suddenly just stricken with this excruciating pain in his upper abdomen, quite a different place from his chest pain. It's just constipation from the narcotics. That was the diagnosis that stuck through thick and thin, through every sort of evidence to the contrary. That was the diagnosis he had. over the course of 30 hours, he continued to deteriorate. He became septic. He exhibited signs of shock and dehydration. He was fairly obviously in bad shape, and no one did anything. Monday morning came, and when they came around to take Lewis's vital signs, he had no blood pressure. And there was just the assumption that that couldn't be right, because how could a healthy child in for elective blood surgery have no blood pressure? They took his blood pressure 12 times.
Judy, I think we've got a problem. We might stop it there.
Okay.
I think there's an internet problem. That's okay.
Okay.
Right,
Do you
so I'll go back to
sharing? Okay. Tracy, I'll just share I'll send everyone a link.
Yep.
They can watch it on YouTube.
That's great. So I think, I can't remember whether you heard that Lewis was admitted for elective surgery because he had, what's it called, pectus excavatum, is that the correct term? Pigeon chest or flail chest?
Flail chest, yeah.
No, so it's elective surgery, and he was having it purely for cosmetic reasons. So what was the diagnosis that stuck?
Well, there was two, wasn't there? It was, first of all, it was pain, and then it was constipation.
Yes. So the pain was related to the constipation. So because they, he was not having his bowels open and his abdomen was distended and he had pain and he was, the abdomen, like I said, was distended. And because he's young, he's healthy, it's elective surgery, it couldn't be anything complex. So as soon as they got the diagnosis of constipation, they didn't have to go any further because they'd nailed it. So, they stopped the thinking process. And because they went straight to the diagnosis without engaging in any clinical reasoning, they never picked up all the other abnormal signs and symptoms and never made sense of them. They went to constipation, they realised he was in pain because of constipation, and the thinking stopped. What's going on? Is that your screen, Judy? Oh no, here we go. So what were some of the errors? Where were some of the problems that resulted in Lewis's deterioration and the lack of clinical reasoning and his ultimate death? What went wrong?
I think a big thing that stuck out for me is that even though a lot of the junior nurses were aware that there was a problem, they were too scared to stand up and say something. Like they could see he was deteriorating, they could see clinically he was, heading south, but, that just astounds me. But I understand it too. I know when I was a new grad and a junior nurse, the thought of standing up to a doctor it's terrifying.
Absolutely. And it's common, and that power differential is so common. In the clinical reasoning textbook, there's a lot of examples of that, people not speaking up because they know they're in a less important role. So one of our jobs is to give students the skills, the communication skills to escalate, to, politely but professionally escalate their concerns and to speak up. Because, you'd have numerous examples where students have identified critical things because they spend a lot of time with patients. So our job is to teach the importance of speaking up.
I've got a great story. When I used to facilitate, I had a third-year nursing student, and she was a UTS student, so I was very proud of her, who had spent a long time with a particular patient. She was doing she had to do a respiratory assessment as a final competency, and it was a comprehensive one that took about an hour. We got halfway through it on one day, and the physio came and said they had to take him away, so we had to stop. We asked the patient if he was happy for us to come back the next day to do it. He said yes. when I came back the next day to do it with the student, she said, oh, look, there's just something not right with the patient today. He's not himself. He's not as, normally he was bright and sparky and chatty as an elderly gentleman. And she picked up, she said there's something just not right with him. His obs were okay. Probably the only difference was his SATs were slightly lower, but still within the flags. But she had told the nurse that she was working with. When I went in to see him, I picked up on it too, obviously not as well as her because I didn't know him as well, but I could tell that he wasn't quite with it. I went out, spoke to the nurse that was looking after him, that the student was working with, mentioned it to the educator, completely dismissed, and he had a stroke about 2 hours later. So she was the one, it was a nursing student who, because she just spent so much time with him and was more, I think, more attuned and hadn't yet been able to develop bias, I think, because she didn't have the skills that she was acting on and responding to what she was actually seeing clinically.
Yeah, what a shame. You know, I've just not longer had a paper published that I wrote with some colleagues from Manchester, and it was about nursing students' experiences of poor care. So I was interviewing, they were interviewing students from Scotland and Manchester, and I was interviewing the UTS ones. And some of the stories they told me gave me so much faith in students. They were third-year students, but when they had, you know, one girl, and we actually put it in the paper, her story, you know, she just knew, you know, there was an older man that was complaining a lot, that had depression and anxiety, and he'd been on the ward for, you know, 30 days. And when he complained, the nurses just said, you know, look, we can't do anything, you know, stop complaining, we can't help you, you're okay. But the student persisted, and she said, no, there's something wrong. She went out to the RNs and they said, he's fine. So she thought, I'm just going to talk to the doctor. So she went to the doctor and she said, I'm just worried there's something wrong. Anyway, he was assessed and ended up in ICU that afternoon. You know, so we have to give students the confidence and the skills to know, and to know when to speak up, and to know that they're not doing it for themselves, they're doing it for the patient. You know, and that really does empower and drive people to act. And it's not just students. You know, when I used to be a new grad coordinator, they hated speaking up because, you know, they had to fit in, they had to belong on this ward. So rocking the boat was a huge problem, but it's critically important. So what else went wrong with Lewis?
I know I've watched the full length one, and one thing that I noticed, they just didn't listen to the mum. She raised concerns over and over and over again. And she's obviously highly intelligent and articulate. But yeah, they just dismissed her. You know, I always say parents know their children better than anyone. If the parent's concerned, I'm concerned.
Absolutely. But I also think it's with adults, because often the family members know that something's not right.
Yeah.
So person-centred care is not just about the patient, it's about the family unit. So listening to everybody. And that's about, you know, when we're collecting information, we need to collect information from the patient, about the patient, in their charts, from the family. You know, we need to collect all the information we can. And one of the problems was they didn't collect the information. They just jumped straight to our diagnosis. And that clinical reasoning error is premature closure. You've got the diagnosis, you have to stop, thinking stops. So there's some quick ways, important and effective ways of teaching clinical reasoning. So, and I'm going to go through these quite briefly now because I suspect that many of you do it. So facilitating deliberate practice, thinking aloud, using higher order questioning, deconstructing critical events, and encouraging and modelling reflection on cognitive biases. That last one's particularly important because there's huge power in saying to students, I made a terrible mistake because I was not aware of how my poor thinking was going to impact that patient. So being very open and saying, you know, I made a mistake. So deliberate practice. I won't read this out, but what I want you to do is think about a tennis coach. They don't help their tennis, you know, the tennis player to become better at what they do by coming every day for a practice session and just saying, okay, well, let's have a game, let's have a game, let's have a game. You'll get better and better and better, because you actually don't. So what a coach does is look for where the problems are. Is it the serve? Is it the backhand? Is it the volley? Where's the problem? So with clinical reasoning, we have to find out what students, what are they good at with clinical reasoning? Where are they missing steps? What parts don't they understand? This can be done in classrooms and it can also be done in practice. We need to get to know their strengths and their weaknesses and give them opportunities to practice over and over again the things that they're not good at. And often the things that they're not good at is making a nursing diagnosis. They can collect the information, they often miss information, but putting it together in the way a good registered nurse does, connecting the dots, they're often not good at that. So they need multiple opportunities for deliberate practice. And you need to find out with each individual student, where are the problems here? What are they not getting? Do they not know what actions to take? You know, is it a knowledge deficit? Do they not know how to make a referral? Do they not know the importance of evaluating the impact of their care? So it's about finding what's going wrong and focusing on that particular thing. Thinking aloud. As I said before, students can see what you do and they can hear what you say. They cannot see your thinking. So it's really important to think aloud, you know, with a patient, with a mannequin, think through what you're thinking about. So students become aware of the complexity and the sophistication and the depth of what you know and how you process what you know. You know, it is the art and science of nursing, but too often students miss it out. And all they think is nursing is just doing, you know, talking to a patient and doing things. That's not nursing. You know, nursing is so much more meaningful than that, but you need to think for them. And you also need them to think for you so that you can say to them, what are you thinking now? You know, talk me through that process. Talk me through why you made that decision so that you know where the gaps are, you know where their thinking is flawed, and you can focus on that particular part. Thinking aloud can be time consuming, but it has a profound impact on students' clinical reasoning skills because they can't tell what you're thinking, you can't tell what they're thinking unless you teach them to articulate it. Then you can see what the problems are. You know, there are some amazing studies that have shown that in clinical practice setting, facilitators, 95% of the questions that facilitators ask are lower order questions. The same study was replicated in tutorials and they found that 90% of the questions asked are lower order questions. You can't teach clinical reasoning skills with lower order questions. We need to really get to the higher level questions that challenge students. So for one example of that might be, you know, a clinical facilitator has concerns about a student's hand hygiene and wants to know about their understanding of hand hygiene. So they could just say, what are the 5 moments? Or they could go to a higher level question and say, can you tell me about the policy that relates to hand hygiene and, you know, the evidence that that policy is based on? And then a higher level question is, can you critique your hand hygiene with reference to the policy and the evidence? And a very high level question might be, after completing the patient's dressing and without removing your gloves, you collected clean linen. Can you critique your actions and the implications for patient safety? You know, students will learn as much as we give them the ability to learn. You ask low order questions and that, you know, any student, first year student can tell you the 5 moments of hand hygiene. Getting to a stage where they can evaluate and critique their practice and understand the implications for patient safety, that's taking them from, you know, 1 to 10. And we really need to think about our questions. You know, we often say, what's Lasix used for? But there's so many other deeper questions you could be asking about diuretics. So we need to train ourselves to ask higher order questions. Okay, I'm going to there's a couple more slides here, but I just wanted to emphasize the relationship between clinical reasoning and empathy. If you think about Lewis's story and the impact on his family, we can respond with apathy and we can say, you know, things go wrong, you know, and that story is just another example of patient safety. They're dime a dozen, Google any, you know, that's apathy. Or you can be sympathetic and you can say, oh, I feel so sorry for her. Imagine losing your 15-year-old son. And that's okay, but that doesn't help us to become a better nurse. It doesn't help us to become a better educator. So empathy is, what can I do to prevent this from happening again? Now, Judy can send you this slide because there is also a beautiful link there about empathy, but I'm mindful of the time. So empathy is not just feeling bad for someone, it's action orientated. If you are not doing an action in response to a patient's needs, it's not empathy, it's sympathy. And empathy is the appreciation of the lived experience of suffering. It's the ability to step into the shoes of another person, aiming to understand their feelings and perspectives, but always to use that understanding to guide our actions. It's a little bit like, if any of you follow me on Twitter, I often make comments about what I believe is Australia's appalling treatment of refugees and asylum seekers. You know, it's almost like, you know, I'm a keyboard warrior, look what I'm doing, you know, because I'm making comments about it. That's not empathy. You know, that's not activism. That's just, you know, it's easy. So empathy is doing something, taking action. And empathy is absolutely integral to clinical reasoning as it allows us to collect and interpret cues related to an individual's lived experience of suffering. They're not just the post-operative kid with pain. They are a unique individual with a unique experience and a unique family. And a lack of empathy can result in collection of limited and superficial cues about people's psychosocial well-being, needs and experiences. All we're doing is focusing on their body. And a lack of empathy can prevent patients from trusting us. And so they don't share all the relevant factors about their health or their health breakdown because they don't trust that you'll understand what they're saying or you won't judge them. And a study I read just recently, which I just loved, it's in a book it's called Compassionomics, and it's based on 200 studies that showed the impact of health professionals' empathy on patient safety. And one of the key things that found that healthcare professionals with high levels of empathy are much more meticulous, much more vigilant, and those with low levels of empathy are more cavalier and detached. So empathy and clinical reasoning go hand in hand. So to finish, clinical reasoning does matter. There's a direct link between nurses' clinical reasoning and patient safety. We have the opportunity and the immense responsibility to teach and assess clinical reasoning, but we also need to teach and assess empathy. And that's it. How are we going for time? We've got a little bit of time for you to ask questions, to challenge what I said, to disagree with what I said, or to add to what I said. And what do you think?
Can I say something? To me, I'm a clinical facilitator with the UTS more than 10 years now. What I think clinical reasoning is one of the beautiful structure in teaching. I always use the one, you know, University of Tasmania, they have a instructor resource that I print out, and it has got every example. So when I tell the patient to take a student to take a patient, and I go through how to collect cues and this, you know, for each patient that they're taking, even from first year. So it really helps them.
Good.
Okay, and also the other thing, if a student is good in critical thinking, following the clinical reasoning cycle, achieve their standards, you know, the 7 standards of competency standards, when you are assessing the students in the clinical performance, make it much easier. To prepare SIOs and all that, make it really easier if the student is good with the clinical reasoning cycle. And also I understand this CRC, it can be used in any situation, a patient admission, also say discharge or inserting an IV cannula or giving medications. Every situation, this CRC can be utilized, and I love it. And I was telling the Judy as well the other day that I love this CRC, and I just feel it's amazing. And one of the issues that I face is when I have an students, those who are enrolled nurses and coming to placement, I just feel that they are missing out on this, and professional identity and clinical reasoning cycle. So it make it really difficult for them to understand this. And I think because they are missing their first years, they are missing out on this. But the 3 years program students, we can train them and they are really getting better, some of them. Of course, some students we need to really put a lot of time to make them understand, whereas some students, they are good. But with the 2 years program, I really find there's not enough understanding of CRC for them. And professional identity in addition, I should say.
I think that's a really good point, Molly, because you need that foundation of knowledge in order to apply it. But, you know, I think we have to teach it on campus. We have to teach it, you know, over and over and over again. But for students, it comes alive in clinical contexts when they have highly skilled facilitators that know the clinical reasoning cycle back to front and inside out. For them, it becomes really exciting because they can see that it informs their practice. It allows them to be a better nurse. So I'm really grateful that you use it and use it regularly, because it makes it much more exciting for them.
Yeah, but what can we do a bit more into it to include the students or teach them a bit more better? I think it's not sufficient. What I just feel like that. Maybe I'm wrong, but I think this is one of the critical areas where all these errors are happening in the hospital, just because they don't have sufficient critical thinking or clinical reasoning cycle. They don't just understand things. So how can we really add this CRC more into the teaching, a bit more in depth and a bit more time for the students to, I don't know, maybe that's what my thoughts are, but I haven't really, I started teaching only this year. So I really don't know, but I just think like students needs a bit more time in involving, teaching clinical reasoning cycle and in the university itself. Because some students tells me I never heard about it. Some students say, oh, first year, little bit we did an assessment, whereas some students are okay. But I have also worked with some other universities and where they give more importance to clinical reasoning cycle. And when they come into the clinical placement, they have a bit of work to do. And they have to submit to the university in terms of clinical reasoning.
Yeah, I think our new curriculum starts next year. And what we have got an integrated curriculum, which means that the things that are most important are integrated through every single session. So they learn it, they apply it, they revisit it, they learn it in more detail every single session. So that by the time they get to third year, they should be hardwired. They shouldn't have to think about the 8 stages. It should just be part of the way they practice. So I think it's anything that's that important cannot be taught once in one subject. Can't even be taught once in one session or in 1 year. And it can't be taught on campus unless it's reiterated in a clinical setting. The things that matter most, students need to hear it from multiple people, and they need multiple different educators and nurses and facilitators to say, this is important. You have to be really good at this. Let me tell you, an example of when I did use it or I didn't use it. So they need to hear it over and over again, and then they believe it. You know, if you give them, clinical reasoning once, it's one of those things they tick off, think, yeah, done that. It really needs to be part of the way they think and part of the way they practice.
Thank you. If no one has question, I just would like to say, when in terms of reflection, in the clinical scenario, in the steps what we are doing, there are 2 issues that I find in addition: setting goals. One of it, setting goals. Of course, we are not making diagnosis as nurses. However, when you are setting goals, say if a patient complains of pain, short-term goals and long-term goals. So that's area, as a facilitator, as a tutor, how do we sort of encourage the students in the lab setting, especially to improve that's what I just thought the other day. I taught ATHC1 last week. I was trying to integrate this clinical reasoning cycle while I was doing things, but then I found that time is not sufficient enough to really, integrate this CRC into the teaching scenario as well. Then I found there are difficulties when I was talking about setting goals and as well as about, reflection area as well.
Yeah.
So while doing, say, respiratory assessment, or, there were a few things that we were doing last time. So
that people have is that they look at the whole scenario. For beginning students, it's important to break it down to, and that's why you do need a nursing diagnosis. If the patient is dehydrated related to postoperative nausea and vomiting, that drives the goals, because then the students, even beginning students, can say, oh, if they're dehydrated because of nausea and vomiting, can't we give them a medication to address the nausea and vomiting? So the goal might be to reduce the nausea and vomiting and increase IV fluids. So it's saying a simple goal for what is apparently a simple nursing diagnosis, so that they can set goals and come up with actions. Sorry, Judy, I interrupted you.
No, it's okay. I just want to say, I guess specific to ATHC2, we'll talk about this week in our team meeting. So can everyone else please let me know your availabilities in the poll in Teams? But from our next lot of labs, so the week 3, 4, 5, 6, 7, 8, the beginning of the lab will be spent going through the clinical reasoning cycle based on the patient from the previous labs. So from next week, in week 3 and 4, we'll do a session at the beginning where we'll go through the process for Mr. Esposito, who they've just looked after in class. Because the clinical reasoning cycle, they've got some activities that are embedded into their pre-work in the lab and in their post-work. So they've had a chance to reflect, look at what they've done in the lab, read through the scenario and started to work through that process. And then we will do it with them at the beginning of the class so that we can start helping them, showing them how to, work through the process. Because like what I love about it, and I love the title of the textbook is, it's learning to think like a nurse. It's just the way we think. Trying to help them to break that thinking process down. So we'll talk about that more in the team meeting later on this week.
Thank you.
Yeah.
And I think one of the most important things with clinical reasoning, it is thinking, but it has to be active thinking. So if you just give them all the information, and even if you're applying it to, like Mr. Esposito or any of the other scenarios, if you just say, stage 1, this how applies, stage 2, this how applies, it's about getting them to give you the answers. You want them to think. So you have to use higher order thinking skills, or do some reading on Socratic dialogue, where the art is about eliciting answers, not providing information. The skill is teaching them to think. It's not like we're delivering a pizza. It's about getting them to create the thinking, create the scenario, to come up with their own answers to your questions and a whole lot more questions, so that it is active, engaged thinking, not just pre-delivery of information, which they'll tune out and they won't remember. They have to be, integral, part of the whole process.
Yeah. So that initial didactic session will be pretty much student-led. It will be, and you're facilitating it. You're challenging their thinking. You're challenging the answers. You're getting them to stretch their thinking a bit, being mindful that they are only first years. But it's, yes, that'll be pretty much, as I said, student-led, with the tutors there challenging, stretching, getting them to think a little bit deeper, thinking outside the box, and then bringing it all back together again. So, but yeah, as I said, we'll talk about that a little bit more.
That sounds good. All right. Well, it was lovely to see you. Thank you for your questions.
Organizing this, thank you.
Thank you, Tracy. That was
Lovely.
great.
Thank you, Tracy. It was excellent. I mean, I've been teaching it for a while, but I've learnt a lot more today. So that was brilliant. So I have recorded it. I'll stop the recording now.